I'm a Dr. Mariia Mikhaleva, and currently I'm a research fellow at Dr. Jennifer Brown's CLL laboratory at Dana Farber Cancer Institute, Boston. I would like to briefly talk about the analysis of mutational burden in treatment-naive CLL patients that was presented at the last ASH 2023 meeting in San Diego. The main rationale of this study was to identify patterns of co-occurrence and mutual exclusivity among mutations in CLL and their impact on time to first treatment. So we conducted the mutational screening of tumor tissue of 795 patients with treatment-naive CLL using a targeted NGS panel covering all or hotspot exons of 95 genes, named the Rapid Heme panel, and this panel was implemented by Brigham and Women's Hospital. We were able to discover 1,798 mutations in 90% of the patients, and 10% of the patients have no mutation. The most mutated genes in the whole cohort were ATM, Notch1, TP53, SF3B1, TET2, and DNMT3A. The study cohort was stratified based on mutational burden, where high mutational burden is defined as the presence of 2 or more mutations. And we found that high mutational burden is significantly associated with a high-risk disease features, such as advanced rice stage, unmutated IgHV status, complex karyotypes, presence of deletion 11q, unfavorable ZAP70, deletion 17p, and also increased levels of beta-2 microglobulin. And in cases with low mutational burden, we're more likely to have deletion 13q and less likely to be treated. Unmutated IgHV cases were enriched in mutated ATM, Notch1, SF3B1, and XPO1. Mutated Notch1 and KRAS occurred with trisomy 12, and as previously reported, unmutated IgHV did not co-occur with mutation in MYD88, and cases with deletion 13q was mutually exclusive with mutated BRAF and B cohort genes. Clinically, the median follow-up time for the cohort was over than 3 years, and the median time to first treatment in patients with DRA mutation was not reached in Kaplan-Meier curves. When patients with 1 or 2 mutation, the time to first treatment was 9 years, and with 3 and more mutation was 5 years. So increased mutational burden showed a significantly shorter time to first treatment. In multivariate analysis, such factors including rice stage 104, unmutated IgHV, complex karyotype, high mutational burden, and presence of deletion 17p with mutated TP53 gene were independently associated with worsened time to first treatment. Also, the matter of interest, neither wild-type TP53 with deletion 17p and nor mutated TP53 without deletion 17p were significant factors in the model. So I would like to emphasize that this study identifies a shorter time to first treatment in a patient with a high mutational burden, the presence of 2 or more mutation in distinct genes associated with the high-risk CLL features. In this cohort, unfortunately, we do not see the co-occurrence in specific mutations. And in multivariate analysis, advanced rice stages, unmutated IgHV status, complex karyotype, high mutational burden, and presence of deletion 17p with mutated TP53 were significant predictors of a shorter time to first treatment. Thank you.